Good morning from Nashville, and thank you to Sages for the opportunity at the podium this morning. I have no disclosures. So how many in the audience have performed a laparoscopic colectomy? All right, good. So I'm going to be, hopefully this will be relevant, and I think I'll probably be preaching to the congregation a little bit this morning. But I wanted to start with what I'm going to tell you, and that is what we found in the National Cancer Database was minimally invasive surgery is used in approximately 44% of all colon cancer resections. And we identified a number of major barriers, which include both patient and hospital level factors. We also found that the rate of utilization of minimally invasive surgery is increasing over the time period of the study. So, a minimally invasive approach has been well described to have a number of advantages over open surgery. These include decreased wound complications, less pain, shorter hospital stay, and most importantly, from an oncologic perspective, the COST trial in 2004 and other subsequent studies have shown oncologic equivalence between open and laparoscopic colectomy. So with these recognized benefits and few drawbacks to laparoscopic surgery, why doesn't everyone get minimally invasive surgery? We hypothesize that there are a number of factors that could account for variation in minimally invasive surgery utilization. These include both patient factors and hospital level factors. We performed an analysis of the National Cancer Database. The NCDB gathers information from hospitals across the country and captures 70% of all annual new cancer diagnoses. We examined colon cancer resections from 2010 to 2012 as those afforded us a variable for surgical approach. We included all colon resections for adenocarcinoma, and we excluded palliative resections and resections performed for any tumor greater than 6 centimeters, as we thought that this might preclude a laparoscopic approach. We identified minimally invasive surgery and defined that as both laparoscopic and robotic approach. We also performed an intent to treat analysis and took conversion as the original planned procedure. So if you were laparoscopic and converted to open, that counted as laparoscopic. We performed bivariate and multivariable regression to identify variables leading toward minimally invasive surgery approach. This is the breakdown of our analysis. After applying our exclusion criteria, we went from over 1 million patients down to our final data set of 124,000. 44% of these utilized a minimally invasive approach, and then looking at the minimally invasive approach itself, only about 6% utilized a robotic approach. So because we had a lot of large numbers in this study, we had a lot of positive p-values too. So I'm going to present a lot of this in graphic form, as I think it better shows the effect size. To begin with, minimally invasive surgery patients tended to be younger. They also tended to more likely be male. And then a number of studies have identified race as a factor in minimally invasive surgery utilization. And while we did find a significant difference in race, it was only about 1%, so the magnitude of the effect was pretty small. However, with insurance, we found patients in the MIS group are much more likely to be privately insured than the open group, and we also found a much smaller number of uninsured patients in that group as well. Looking at other socioeconomic factors such as income and education, the minimally invasive surgery group tended to have a higher income. And when we looked at education, we defined low education as greater than 21% of the population not graduating high school. You can see here that the minimally invasive surgery had a much lower percentage of low education patients in their cohort. So maybe it's all due to comorbidity. You don't want to do laparoscopic surgery on a patient with high comorbidities. Maybe it also has to do with travel times as well. But in both of these, while these turn out to be significant, the difference is extremely low. Most of the patients in both groups had minimal comorbidities, and the distance traveled greater than 20 miles was similar in both groups. Looking at some hospital factors, we looked at both facility type and volume. And you can see that patients in the MIS group are more likely to be treated in an academic research program as opposed to a comprehensive community care program or a community cancer program. And then in volume, we created terciles based on annual hospital volume which worked out to be about, low was 0 to 12, middle was 12 to 25, and high volume was over 25 total resections for cancer in a year. And you see a much higher percentage of high volume hospitals in the MIS group. To try and account for any potential biases, we performed a multivariable logistic regression. And again, you can see that we had a number of significant findings, but again, it's worth looking at the effect size. So when you look at age, female gender, and race, all of these are within about 1/10 of a point off of 1, whereas you see a much higher effect size here in insurance type. Uninsured patients have about half the odds of receiving minimally invasive surgery than patients who have private insurance. Looking at other socioeconomic factors too, things like low income and low education also go into having lower odds of having a minimally invasive approach. And then looking at our hospital level factors here, you have a decreased odds of minimally invasive approach if you receive treatment at a community cancer program relative to an academic program, and you have almost somewhere between kind of 40% less of a chance of having a minimally invasive approach if you go to a middle or low volume hospital. This is the same thing in graphic form. Just shows a little bit better the magnitude of difference. You can see especially here it's pretty close for things like race. But when you look at insurance status, right here, uninsured is, again, offering about 50% the odds of receiving a minimally invasive approach in an relative to a private insured group. Other larger things you can see here is regional variation, which I'll talk about in a little bit, and then volume here as well. So in talking about regional variation, we saw a large range of utilization across the country. Down here in Houston, had about a 37% utilization rate. Where I practice in Nashville, we're a little bit more in the middle, about 42. And then the New England area had a 53.2% utilization of minimally invasive surgery for colon cancer resection. We also looked at the change by year too and saw a pretty drastic increase of minimally invasive surgery utilization over the time period, going from 38% in 2010 all the way up to almost 50% in 2012. I think there are a number of limitations with which we need to appreciate this analysis. We didn't have any data on BMI, previous surgery or adhesions. I think those are all things that play into the factor of whether we offer a patient a minimally invasive approach or an open approach. We also had no surgeon level data, so where your training was done, how old you were, what level of training that you had in laparoscopic surgery. And the NCDB, despite capturing almost 70% of the nation's cancer cases, is not a population-based survey. Moving forward, I think there are a number of things that this study talks about. This data provides targets for the dissemination of laparoscopic technique. The Department of Health and Human Services identified the elimination of disparity as an initiative of Healthy People 2020. Focusing policy on expanding laparoscopic access to patients regardless of race, insurance status, or socioeconomic status should be a priority of this society and others. And then also the idea of centralization comes up. Do we need to start promoting centers of laparoscopic excellence? And I think that this kind of may act contrary to patient preference. So again, this is hopefully what I've told you, and I'd be happy to answer any questions.
Thank you.